Thanks, Premier. Yeah, I would say we're following, at a minimum, the national guidelines for outbreak management and contact tracing, and we're going above and beyond that. We are following casual contacts, and we're asking them to test when they've been exposed at exposure sites. So we are doing an approach that is the same across Australia, at least at the minimum level as defined in the national guidelines, and above and beyond that. So the 12 cases today, 1 probably not real, and 11 linked to known cases. That means, by definition, there are no cases of unknown acquisition for today. That's what we want every day, and when we have cases who are in isolation at the time that they get tested and get that positive result, they're not going to be exposing anyone else, and so we'll see these numbers drive down.
So Rachel, can I just finish this one? So I guess the question would be, if this approach is now being done in Kilmore, where you are doing close contacts, telling them to isolate, telling asymptomatic people to get tested, why has it taken until now for that approach to be phased in as it's been described? Why was it not being done, say, in the Chadstone outbreak? I mean, if you have a look at some just back of the envelope, if you take out the Frankston-Chadstone outbreak, we would have an average somewhere around 7, and we'd probably be on track to open on Monday. So why was that not done in the case of Chadstone? Why has it taken until now?
No, we've done it in the Chadstone case as well. So people who are casual contacts of that site, anyone who's been through Chadstone, who hasn't even been to the Butcher Club, hasn't even been to Jasper's Coffee, are being prompted to get tested. So that is much, much broader than the previous approach for outbreak management. And so it is akin to the Kilmore outbreak. The issue with the Kilmore outbreak is that there is a burden for contacts of contacts to be isolating. We've got hundreds of people isolating in Kilmore. I think they accept that as a legitimate and proportionate measure to control that outbreak, and we haven't had new cases. We've had half of those get their day 11 quarantine testing. They've all come back negative. The other half will be done today. I expect that they'll be negative as well. So I think this is an approach that is as precautionary and proportionate to the task ahead of us.
Just to finish off, it wasn't done originally with Chadstone. You were saying that if you're even mildly symptomatic, come forward and get tested if you've been to Chadstone. That's not everybody. That's not close contacts. And I guess the question is, you would have had, I would guess, significant public support for an approach like you're taking in Kilmore. Why was it not done in the initial stages of Frankston and Chadstone? Why was it only in Kilmore that was started to be phased in?
So an approach of testing every single asymptomatic person who goes to a particular setting when there are tens of thousands of people coming on a daily basis is not value for money and is not necessarily a proportionate approach. We had people who were known to be positive with casual exposure in Kilmore, and so it was very clear that the epidemiology suggested that there was a very infectious person in that setting, and they had gone to that specific setting. We're talking about a number of shops in Chadstone where people hadn't gone anywhere near any of those exposure sites, and so to open it up to every single asymptomatic person would not necessarily have been proportionate. We're still saying anyone who becomes symptomatic get tested, anyone who becomes symptomatic isolate at the first sign, and we're seeing every single case that's linked to that.
New South Wales has been open for months with similar daily case numbers to what we've had for the past 3 weeks or so. What's the difference between New South Wales and Victoria?
The differences are really profound. When I spoke recently about the cases that we've had in Victoria, when we had 20,000 cases in this second phase, or wave, as is a kind of lay term that's not necessarily a technical term, but through this second wave, the 20,000 cases that occurred across Victoria settled into the hardest cohorts and populations across the state, including in metropolitan Melbourne. The household sizes I've spoken to, so average household size in Victoria, 2.5 people. We're thinking that on average, the household sizes that we're following up are 2 to 3 times that size. That means more workplaces exposed, and it goes on exponentially. Those workplaces have people working there who have households that are 2 or 3 times the size of an average Victorian household. So the number of close contacts per household and the number of close contacts they have is hugely different. And we are coming down from 725 cases per day down to our 10 to 15 cases per day. We are not building up from a trickle of a small number of cases in small households with without some of the challenges of casualised work, of cash in hand, of issues of visa status, issues of language and cultural barriers. And so the challenge in Victoria is profoundly different from equivalent case numbers in any other jurisdiction of Australia.
An advisor to the World Health Organization has urged governments not to use lockdown as the primary method of controlling the spread of COVID-19. With that advice, would you consider revising the strategy?
Well, we have followed a strategy that is not using lockdown interminably. We are using the restrictions that are in place now to drive the case numbers down so that we can get to the very thing that WHO is talking about, not having restrictions in place in the long term because you can control at a sustainable level. Either, as is the National Cabinet decision and the national strategy, no community transmission, 0 cases of community transmission, that's nationally agreed, or if we can't get there, at a level of a few cases per day that is sustainable in terms of follow-up and management of the outbreaks and the contacts that we need to follow, if that's the case. So we're not out of accord with WHO advice, and WHO advised 200 countries and regions of the world, almost all of whom are not at this point, almost all of whom will need to manage a much more significant ongoing level of transmission. And they're speaking to the harms of restrictions that are in place ongoing. We are mapping out, as is explicit in the roadmap, a gradual easing to a point where we're getting to a COVID normal. So in that sense, WHO would be supportive, I imagine, of that kind of path that leads to the lifting of restrictions that allow people to have their well-being and health and psychological health supported.
How is the 5 kilometre restriction? There seems to be growing need among the community to have it expanded or removed completely. A couple of weeks ago we did ask Alan Chang how we came to the 5 kilometres, and he said that it had been successful at reducing movement, but he couldn't really give a reason. I think he said 5Ks, 12Ks, it's an arbitrary figure. So can you just talk us through why it's 5 kilometres opposed to 10?
Look, it is ultimately a decision about what is proportionate for reducing the amount of interaction from one person to another person, one household to another household. You could choose different distances. As I've mentioned previously, Israel's down to 100 metres from your home. Spain went to 150 metres for weeks and weeks on end. 5 kilometres is a judgment about where people can reasonably go for exercise, where people could reasonably go for the permitted reasons without increasing too significantly the number of other people and households they come into contact with. When you double that radius, you're multiplying by 4 times the number of households that you can potentially come into contact with. So it's just trying to make a judgment about limiting interactions to an extent possible, but allowing people to have some opportunity to find a park, find a walking trail for the purpose of exercise.
Considering people in outer suburbs and semi-rural areas with less density have fewer friends and family, not as many parks, not as many shops in their 5Ks. How conscious are you of the, I guess, disproportionate penalty that it imposes on them? Yeah,
I think that, there are so many things that are applied across the board that are more difficult and more challenging for some individuals. That's well known to us, and it's really tricky. You can't make individual rules for individual households. We've tried to look at particularly challenging circumstances. The single person bubble was trying to address that. The intimate partner exemptions were trying to address that. But I totally accept that not everyone lives in the same kind of neighbourhood. Not everyone has the same opportunities. For people who live 5 kilometres from a beach, terrific. But not all of us do, clearly. But that will be in consideration as we come to this weekend as well, as we think about that. But it's not easy.
Sorry, can we just finish the 5K zone? On that point, considering that there are a lot more measures that you've got in place, like testing people in quarantine, more contact tracing, would you be pushing for that zone to be expanded?
Oh, I'm not pushing for anything. We are reflecting on all of those elements as we come to this weekend about what can reasonably change with what we're facing at the moment. So yes, it's up for consideration, as is everything.
We heard the Premier yesterday say that this could be as good as it gets in terms of case numbers. What's the inverse to that? What's the ceiling that we can really accept before cases start to get away from us, or before we start to see pockets of lockdown again?
Oh, it's a difficult judgment to make. It's clear that any country that has hundreds of cases per day doesn't do contact tracing at 100%. Doesn't matter where you are in the world. The United Kingdom that's invested $10 billion into contact tracing and has a team of tens of thousands doing contact tracing are getting to about 2/3 of their daily cases at all. Not even in a timely way necessarily. So there are clearly limits to what contact tracing can manage, but we've got a team of a size that could manage dozens and dozens of cases per day, but that is not the entire solution to how you manage transmission risk. So masks and distancing and the behaviours that people engage in routinely, keeping that 1.5 metres as they go shopping, as they buy food, absolutely critical measures in the mix. That applies across the world at the moment. It's a different way of living, and it's not easy to change some of those habits, although it's pretty clear that we've habitualised a lot of those really important things. But contact tracing cannot do the entire work of preventing transmission, because the human behavioural elements are really critical as well.
So is there a figure of where the Victorian contact tracing team starts to become overwhelmed?
No, I don't know that there is. I think again, it's not even a question of being overwhelmed. It's a question of what drives transmission. And when you do contact tracing, you've already got a case. You're following their close contacts and you're managing their quarantine. But the risk of transmission also relates to how each and every person moves around before they become symptomatic when they're infectious, and then how they're interacting before they get notified to the department. They're things that are not within the control of any contact tracing team anywhere in the world, because they're things that happen before a case is even notified. So they are really critical elements as well.
Of those 11 cases that have been linked to outbreaks, do you have a rundown of what outbreaks?
I do. So one's a household contact of a known case in the Chadstone outbreak, so obviously in quarantine. One linked to Estia Keilor aged care. 7 linked to a case from Box Hill Hospital outbreak, including 4 cases from the same household. 1 is being investigated for links to the Chadstone outbreak, a separate one. 1 with links to Uniting Agewell in Preston. And the last one, I'm presuming, is the Geelong case that the Premier alluded to. I think that's residual virus, probably dead virus, still gets picked up with the viral fragments on a swab, but isn't infectious. But we need to be clear that it's not a reinfection. They're rare events. They can happen for people who've been previously infected. So there'll be a review by an expert panel of that today. But I'm pretty confident that will be regarded as a residual infection and won't be counted in today's numbers.
Just Box Hill. Sorry, got the same question as me probably. Box Hill, is there healthcare workers in that 7?
No, I believe it's household contacts of cases in Box Hill.
Just on the Box Hill outbreak, doctors have said that hospital is still without some critical infection control measures. How is that still possible, given we're so far into this pandemic response?
I don't know that that's the case. It might be a claim being made, but I don't know that that's the case. As I said previously, our Chief Medical Officer, Andrew Wilson, is the lead for clinical settings and PPE, infection prevention and control. I think he spoke on radio this morning. He might be able to provide some additional details, but the support to health settings by our health services pandemic leadership team and all of the guidance absolutely covers the requirements for healthcare settings to manage infection prevention and control.
There is suggestion that the COVID ward and non-COVID wards are actually sharing the same tea room without it being cleaned in between. Has that been raised with you?
No, it wouldn't be raised with me, as I say, but it might have been raised with the Chief Medical Officer, and we can come back to you if there's information about that.
Brett, do you know how we're going at the moment with turnaround times, getting to close contacts, getting the interviews done, getting those test results back? Is that...
Yeah, no issues there at all. Turnaround time is at 96, 97% for pathology tests to come back. So the vast majority of people, will, if they're tested in the morning, will get it the same day. Everyone else will get it the following day. So that's fantastic. A number of them are, within a 12-hour window. So that's fantastic by our pathology services. In terms of contact tracing, from time of notification to time of making those phone calls, the vast majority are being done within 4 hours, let alone 24 hours. So no issue there. The challenges will be the time that people take to get tested and the people that might be exposed in that period of time, and the time that people are isolating from becoming symptomatic. They're really critical things.
You're still concerned about that aspect of things?
I am. Look, any public health person in the world would say they're really important measures to reinforce, because they are much harder to control after the fact. You've already exposed people, they're incubating, they can become positive down the track, and it gets away from you in that sense. That's when you get 10 people in a household who are becoming positive, even though you've done contact tracing with the case immediately, because they've already had 3-4 days of exposure. So that makes it very challenging. So I will continue to reinforce that message. Isolate immediately on symptoms, and for everyone to be aware that there's that $450 payment if you have to take time off work because you're waiting for a test result, and there's that $1,500 payment if you have to isolate or as a close contact have to quarantine for 14 days.
Professor Sutton, it's just been confirmed that New South Wales has recorded 13 new cases today. That's more than Victoria, but we're still in lockdown.
So the circumstances in New South Wales are very different. They have prospectively followed a small number of cases over recent months where they've looked forward to the contacts that they have and managed them appropriately. If we had started with a few cases that were not really complex households, that were not really challenging circumstances, we might have been able to approach this very differently. What we had was 20,000 cases over several weeks that have come down to a very low level, but the remaining chains of transmission in Victoria are some of the trickiest, I imagine, in the world.
Can you understand why Victorians are starting to lose faith in this strategy? I think everyone was so understanding that we had to go into a tough lockdown when we were getting so many cases, but now New South Wales is more than Victoria has. It's so frustrating, and it's just been so many months. And
there's no question it's frustrating. I'm frustrated. Everyone is frustrated. Yes. I'm not sure that people are losing faith.
Like there's a light at the end of the tunnel. Like this, we were all looking to this weekend.
So the roadmap, I would say, is the light at the end of the tunnel. The fact that we are reviewing, reviewing the case numbers every single day is an important thing that Victorians would expect of us. That we make judgments about where we're at, so that we're not taking an unreasonable risk, that we're going back to restrictions, or that we're needing to reimpose, or that we're going to get to hundreds of cases a day by Christmas. Victorians would want to know that we have the confidence of being able to keep numbers low or drive them down to extremely low levels right through as a sustainable and long-term issue. There's no question there's frustration. There's no question that people are hurt and harmed by the restrictions that have been in place. But the roadmap is laying out a pathway to easier and easier ways of living at the same time as managing case numbers. I think that's really critical.
But the roadmap also has its problems. It said that we'd be getting to 5 cases by Sunday on average, and we're not there. So why are we following this roadmap that has targets that are not attainable? So
as the Premier has already spoken to clearly, the roadmap was requested. The roadmap was a desire for people to see what the modelling demonstrated, what the kind of targets were for us to make decisions. The fact that we might at some point have looked ahead of it, at points looked on track, at other points looked a bit behind, is the reality of this virus. And we have to make judgments about the number of mystery cases we're getting and the rolling average. And if we're not at that point yet, and that represents an unreasonable risk for us to take, then we will alter the changes that we need to make. We will make decisions that are safe and steady, but we will always keep in mind doing the most that we possibly can to open up in a safe way. Nobody wants this. Nobody wants restrictions that are in place if they don't need to be. And so we will always look to lifting that, but in a way that doesn't put everything that we've done at risk.
Just in terms of the mystery cases that are current at the moment, were you aware or do you know how old or how young the youngest is?
In terms of age of those individuals, I don't. I can come back to you with that. There are two new mystery cases, not from today's numbers, but that are finalised for today. Postcode 3024, so that's Mambarin, Mount Cottrell and Wyndham Vale, and 3025 Altona North. So as I've said previously, it doesn't mean test here and don't test anywhere else, but anyone who's symptomatic in those postcodes, there are chains of transmission around you. You should get tested if you have any symptoms whatsoever. Just a scratchy throat, just a runny nose, any fever, any new cough, get tested.
Are you aware of any children in those mystery cases?
No, not from these numbers, but I don't have the details. I'm sorry.
Where are we up to with the suburban contact tracing hubs and setting those up?
Yeah, they are developing well.
Are all of them up and running at this point?
Yeah, they are all up and running. They need to develop in line with the maturity of that setup, and so the allocation of cases to them has started, but they're not all equally linked into community health centres or community-led bodies, and so they need to establish some of those links, because it's that community-led engagement that's really critical for those suburban public health units. But
when do you think you'll be able to say that you're confident that those links have been made?
Oh, I think it's up to those health services that are helping to establish them to make that judgment. I think they're always going to say that they can work to have more extensive and better established community links, but it's a work in progress. I think they all understand how important it is to have that level of engagement in the public health response.
Brett, what's the timeline from someone becoming infected to when they then become infectious and when they show up test results?
So a person can be infectious up to 48 hours before they develop their first symptoms. This is why masks are really critical, and this is why some people get exposed to someone before that individual has symptoms. They are usually most infectious just before those symptoms start and for the few days afterwards, the first few days afterwards, but they are potentially infectious up to 10 days after symptoms begin. But usually in the first few days they are most infectious. That's when most transmission occurs, day 1, day 2, and in the day or 2 previous.
And how long from point of infection or moment of infection to becoming infectious?
A moment of exposure to becoming infectious is that incubation period, and that's 14 days. That's why people are quarantined for 14 days, because from being exposed, the longest period of time before developing symptoms is 14 days.
Questions for Premier?
Sure. Can we ask about bushfire risks and whether we've missed